Good morning, everyone. My name is Carla Sanz, Regional Advisor for PAHO, and it is my pleasure to welcome you. I want to make sure that all those who require interpretation into English know how to use it. In order to start, I will invite Dr. Sebastián García Saiso, who is Director of the Evidence and Intelligence for Action in Health Department. Thank you very much, Carla. And thank you all for being here today for this very important seminar on ethical guidelines for public health surveillance. It is a pleasure to be with you and say these brief works that will be a framework, a discussion about a document that has already been with us for a while, but which since the COVID-19 pandemic has been highlighted both in terms of epidemiological surveillance and public health surveillance in general, as well as highlights ethical guidelines of this kind of surveillance, which are key toward resilient health systems. Uh, Today's session will be a general presentation on surveillance guidelines. And we will also be hearing different experts from different areas in PAHO, and they will reflect on the experience regarding the implementation of these guidelines and some elements that are essential so that they are included within political healthcare policies and strengthen surveillance in public health. We hope that this session on ethics and public health will be a part of the core and the focus for regional strengthening, and this will lead to a healthier environment with more well-being for everyone in the region of the Americas. Thank you very much for your participation from our Evidence Intelligence in Health Department. We greet you, and also we greet you from a special greeting from Dr. Jarbas Barbosa, our director. Thank you. Thank you very much. And yes, in fact, now we're going to have a presentation. It will be a short presentation on the surveillance guidelines, which are now available in the four languages of our organization. All the questions that you have can be sent using the Q&A button, because at the end of the session, we will have some time devoted to reading the questions and answering them. We can have a dialogue about the ethical challenges in surveillance. So let me share my presentation here with you. These WHO guidelines on ethics in public health surveillance are the international framework for ethics at international level. As Dr. Garcia Saiso said, they were initially published in 2017, and in developing them, this led to a great reflection to make sure that they are sufficiently comprehensive and they really involve the different kinds of surveillance in public health. Why do we need some guidelines for surveillance in public health? You may be wondering. Well, in fact, COVID-19 pandemic led us to visualize the importance of surveillance in public health. What we've seen since we started the work of developing these guidelines up until this point is that often guidelines for human beings are erroneously applied on surveillance, but this is not warranted because surveillance and research are different activities. Yes, in fact, they have things in common, many things in common. They're both systematically collecting data, but these are different activities with different goals and objectives, and they use different ethical frameworks. Back in 2017, we had a large collection of ethical orientations for research, and we had none for surveillance. But today, this orientation continues to be the only comprehensive framework that we have worldwide to do public health surveillance in an ethical manner. Some of you may be wondering, well, how do we distinguish between research and surveillance? Because both presuppose collecting systematic data in a rigorous way, in an organized way. But the difference between research and surveillance is the objective of the activity. Research has the objective to produce generalizable knowledge. Surveillance has a different objective, which is to improve health of the population through advocacy, planning, executing, and evaluating public health practices. In other words, the data and the samples collected, analyzed, interpreted, and shared for surveillance have the purpose of producing direct benefits for the population whose data are collected. Therefore, it is essential to realize that while there are two different activities, it's not that ethical challenges are exclusively for research and that surveillance has no ethical challenges. No, surveillance makes us face many ethical challenges. Some are similar to the research ones, especially when we are working with human beings, especially collection of data and data analysis, sharing of data. The breaking of confidentiality, lack of respect of people and their autonomy, and stigmatization, which is a risk also. But there are some ethical challenges that are basically different from those that we face in the context of research, and which just are directly related to the they have to do with the surveillance specifically. For example, protection of individual interests and other matters. Why do we need ethical guidelines for public health? Well, because we need to do surveillance. Surveillance is essential to reduce inequities. And I'm going to talk about the importance of this. But when we do surveillance, we have certain ethical challenges, and they are like an itch. We wonder, is it okay to collect individual data? Are we intruding in someone's privacy? Is it warranted? Are we risking to do discrimination? Is there potential here to stigmatization? This concern, whether we are doing the right thing with surveillance or not, can be exacerbated when there's no public trust in the work of the health authorities, and also because surveillance is a central task. And if it's going to be successful, it means that society needs to trust it. And this is why we need ethical orientation for surveillance. And I would dare say that this need is exacerbated because many of these discussions about ethical challenges in public health continue to be dominated in our region by mentions to legal frameworks or the law as the only tool, invocating individual rights, as if all health matters were related to personal decisions, when we know this is not true. And if we talk about social determinants of health, we are reminded that this is not the case. These guidelines are framed within the ethics of public health in bioethics specifically, which has to do with health challenges for populations and which recognize the mandate of a health authority to protect and promote the health of people and prevent diseases. This particular part of bioethics, the ethics of public health, has been recognized as a priority in the document of the governing bodies issued in 2012. And this is why bioethics in public health continues to be one of the pillars in bioethics for PAHO. If you want to learn more about public health ethics, we invite you to take this course on public health ethics, which is available on the virtual campus, which is located in the Puerto Rico node, but which is accessible by the whole region. And this course provides or offers a certificate for those who complete it successfully. Unfortunately, right now it is available only in Spanish, but we hope this will change soon. If you review the publication, you will see that there are certain ethical criteria which are essential for public health surveillance, and that is in the publication. It is for the common good, for everyone. Equity understood not only as justice, in other words, treating everybody in the same situation, uh, in the same way, but also a call to prioritize those who are in the worst situation in a society, respect to people understood as a concern for their rights and the well-being of the population, not only as concentrated or focused on individual people or persons, but also, and finally, governance, which calls for transparency in accountability. So, what are the questions on ethics in public health surveillance, which we are seeking here? And let me highlight that this is a document on ethics that has been written by ethicists, which we hope will become a tool for those who are working on the field during doing surveillance. So it is clear, uh, giving concise guidelines regarding obligation, mandate, and what is assumed by this obligation, risks, how are they to be minimized? How do we respond if a risk becomes a damage? What obligations do we have to share data with others? Under what circumstances? With whom do we share and with whom don't we share? There are situations, or are there situations where sharing data should be forbidden, or should they be required beyond being allowed? What is the role of the community in all of this, given that surveillance is a task which seeks to provide public health care, not individual health care needs? And what are the institutional governance mechanisms for public health surveillance? And let me reiterate, as this publication reiterates, the ethical obligation and mandate to do surveillance. And let me read you this quote. Without public health surveillance systems, we cannot protect the health of the population, nor can we tackle inequalities appropriately. The lack of meeting the needs of public health erodes trust. So, from the standpoint of the common good, when countries and communities and the international community cannot do public health surveillance adequately, we are facing a serious moral problem. And as Dr. Garcia Saiso emphasized, COVID-19 has called the attention about the importance of doing surveillance and how it is a central role in public health surveillance. Is that the ethical obligation to protect the health of populations and respond to inequities is what justifies the mandate to do surveillance. Our panelists will share their experience and will give us their points of view and talk about the specific areas where they work in surveillance. But what is not accounted for does not count. In terms of surveillance, let me also emphasize that surveillance should always have a clear objective of public health, a plan to collect data and analyze that data. And there should be rigor in all of these surveillance jobs. It's not only a technical task, it is an ethical matter. And now, I will briefly refer to the different guidelines in this document. The numbers in blue refer to the specific guideline as mentioned in the publication. And they are not necessarily, or in my presentation, I'm not following a numerical order, but I am sharing this in an easier way to understand and follow. The first guideline is that countries must develop adequate, viable, sustainable surveillance systems with a clear plan to collect, use, and um, disseminate data. So it is not only a matter of opportunity. Uh, Surveillance data, which are collected, must have a legitimate public health objective. We don't collect data just to collect them without a clear objective, because the objective is that which warrants the public health surveillance. Data should be quality data, timely, uh, valid, accurate to achieve the objective that we are proposing. Uh, and here, number 5, it should be a transparent process to plan surveillance. What is the objective, the goal? How are we going to go about it? And another sensitive issue here is that not all of us have the same amount of resources to do surveillance. So number 6 says that the international community has the obligation to support those countries that do not have enough resources for surveillance, because we know that public health problems don't know anything about political boundaries. Uh, and then we jump to 11. And under certain circumstances, collecting names or personally identifiable data is warranted. Now, number 12, guideline 12, acknowledges that people have the obligation to contribute when full, accurate data are required. And this obligation on the part of the population is essential from the standpoint of public health ethics. And it is something that we have emphasized at PAHO within the context of the Zika outbreak, but also in the context of the COVID-19 pandemic. It is a moral obligation, not necessarily translates into a legal mandate. And there is clarity in the guidelines that informed consent is not necessarily a requirement, because it is not a standard by default in surveillance. Also, in each case, we need to understand whether it is appropriate and to have an informed consent process. But we need to make sure that people always should be treated with respect. Treating someone with respect is not synonymous to ask for their informed consent. Informed consent is a process to assure the willingness of participation by someone and willingness of having certain information or not having them may be inappropriate in certain circumstances, and we should not depend on a person's willingness to, for example, share with the national authority a significant risk of an infectious disease that will put the health of the population at risk. Treating people with respect is what is always essential. And they should be informed of why data are being collected and for what. And it also, if it were necessary, their informed consent should be required or should be asked. And even in those situations where it is not appropriate to request informed consent to obtain data for purposes of surveillance, you can consider asking a person for their broad informed consent to use these data, these samples in the future for purposes of research. These are different things, but you can take that opportunity to ask for that kind of permission. Those of you who are interested in this topic, please review the international ethical uh, guidelines related to health in human beings and also catalyzing ethical research in emergencies. Chapter 6 is specifically devoted to this topic. And let me share with you the QR code so that you can access the webpage for this publication. And now continuing with ethical aspects in surveillance, number 7 calls for considering values and concerns in the communities. Number 8 calls for identifying, evaluating, minimizing, and revealing or report what risks are in doing surveillance. And in case these are real risks that will become damage, and then this will lead to monitoring and mitigating the damages. Number 9 talks about surveillance in those who are susceptible or more susceptible to suffer diseases, damage, or injustice. And we know that doing surveillance in these groups of people is critical to ensure equity. Instead of saying these are challenging cases, we will leave them out. What we should do is that there is careful scrutiny in order not to impose unnecessary burdens on these populations. Number 10 makes a calling to governments and agencies to carefully protect individually identifiable data from individuals. Many of the data I have just shared with you will resonate with certain specific PAHO orientations published recently, especially the ethics in epidemiological surveillance for uh, Simpox. And of course, there's a wave now, and maybe this publication is being consulted even more now. Regarding communications and sharing, we have a set of guidelines here, 13, uh, which is the relevant target population that can benefit with this that can benefit from this information. Also, other health agencies that could be involved. Number 15 is the urgency of sharing accurate data in a quick way during public health emergencies. And then number 16, the importance of sharing with other agencies or other entities with the purposes of public health. For example, sharing with a view to research, but of course, taking care of that the due safeguards are maintained. And number 17, identifiable data should not be shared with those who can use it or are going to use it in acting against people or for purposes that are not related to public health. In other words, law enforcement and other situations with migrants, for example, etc. Regarding ethical supervision or oversight, Number two talks about appropriate and effective mechanisms to make sure that public health surveillance be ethical. Surveillance is a continuous job, and oversight should be essential and continuous too. It should be continuing. It's not a matter of having a checklist, but it should be continuous and substantive. We also need to be transparent regarding what data are shared, what data are collected, and for what purposes. This transparency is essential to promote trust in the population for uh, their cooperation and engagement in public health situation. And so there need to be concerted work between authorities and the population. The guidelines are clear that we should not be replicate ethical mechanisms that we have for research, because surveillance is continuous as opposed to research, which has certain instances that are not continuous over time. And if we maybe we can use some strategies that look more like research, but no, for having ethical oversight, training in ethics as a kind of training that we are providing now, which sensitizes on ethical orientation and challenges, and finally, strengthening the capacity to do an ethical analysis is a must. So I invite you once again to take that course.
We invite you to review the document on these guidelines and to join our ethics or public health ethics network, in which we undertake activities and issue relevant publications related to the ethical guidelines. Now, without further ado, it is a great pleasure for me to be able to get our discussion started today in our panel. And I wanted to reiterate that from the PAHO standpoint, the fact that surveillance ethics is part of what we need to do. It's also something that is part of the organizational principles. And in this sense, it's a great honor to have this panel today, because these are colleagues with whom I've been working for a great deal of time and from whom I've learned extensively about the technical work behind surveillance. And these are people with whom we work very closely in a routine way to ensure that the work that we conduct in public health from the PAHO perspective is always ethical. So with that, I'd like to introduce Dr. Marta Savoya, Senior Advisor for the Elimination Initiative of PAHO. She is part of the disease control department in the organization. You have the floor, Marta. Thank you very much, Carla, for the introduction and for the invitation. Good morning, good afternoon to all of the colleagues that are joining us for this important session. Today, I'd like to share with you some comments and insights regarding the importance of ethics in the disease elimination agenda, and how these guidelines that Carla has shared with us in her introduction really serve to guide the work carried out by the Pan American Health Organization in its technical cooperations with different countries. We don't just provide these guidelines, but we apply them to the work that we conduct towards disease elimination. And we do have these guidelines that are so important for our efforts, because we live in a region with a very long and rich history in terms of communicable diseases. And we have made some inroads in the elimination of certain diseases through vaccination, such as smallpox or polio, measles, rubella, and congenital diseases. But we've also achieved some progress in other regions, such as vector transmitted diseases such as malaria. or others such as onchocerciasis, Chagas, or rabies, or the maternal to child transmission diseases. All of these circles that you see here contain the name of a disease that was eliminated. And all of this was achieved through interventions directed at public health. But in addition to the elimination of disease, we've also needed to count on surveillance activities because this allows us to understand what's happening with diseases, the various factors that drive diseases in different populations, and it also helps us assess the impact of the interventions carried out in each country or in each population that we work with. So this is key for the elimination of diseases and public health surveillance that is driven by ethical guidelines is absolutely essential. In 2019, the member states of the Pan American Health Organization and its general board approved the framework that we presented to eliminate multiple diseases, taking advantage of this rich history of disease elimination and eradication that we have in the region. And we tried to look at this from a more integrated perspective and accelerate the elimination of diseases, taking into consideration that many of them affect populations that live under certain contexts that we are able to identify and deal with. This is not going back to the eternal discussion of the top-down or horizontal application. What we're looking at here is the elimination of diseases based on four common axes that are common to all of these problems. First, strengthen the integration of systems and healthcare services that deal with diseases at the population level based on their context. Malaria and other diseases exist perhaps because of certain uh, circumstances that serve to drive the existence of the diseases in these populations. And so when we address these programs, we can look at these more carefully, analyze the different factors, and perhaps identify those points or spaces where we can accelerate the treatment as well as the design for systems to eliminate the disease. Secondly, we need to strengthen the current information and surveillance systems, which are essential to our efforts. Additionally, we need to approach the social and environmental determinants related to health. These will allow us to perhaps accelerate disease elimination for many diseases. And lastly, we need to strengthen our governance and financing as well as accountability mechanisms through a lifelong approach and through decisive actions related to human rights, gender equity, and other vulnerability factors. So the current list includes approximately 30 diseases and conditions that were prioritized because these were diseases that we could deal with given the tools that we have available to deal with them, and it is technically feasible for us to eliminate them. You can see the list of 30 diseases. I'm not going to delve too deeply into these. You're going to have a copy of this presentation after the session, but we have four large groups, those that we can eliminate and that continue to be a very serious problem in the region. And these are diseases produced by virus, parasites, such as the papillomavirus. So we want to eliminate two critical environmental factors, such as defecating outdoors and the use of contaminating fuels within the homes. We also want to maintain and protect the progress that we've already achieved in the Americas, especially diseases that are caused by vaccination. And we also need to eradicate other diseases that affect the region, such as hoof and mouth disease. So surveillance at the national, subnational level is absolutely critical to be able to eradicate diseases. First, we need to assess the fragility of surveillance systems from an epidemiological standpoint. We need to provide populations or address populations that have a fragile surveillance system in place or have basic epidemiological silence. So we need to provide baseline information on disease transmission, the coverage and impact of interventions, and surveillance helps us understand the impact of the interventions, the coverage of these interventions, but it also allows us to identify determinants and inequalities that the population is subjected to, not just as an exercise in data collection, but to collect necessary information to not only accelerate the interventions as well as their effectiveness, but to also create an archive that will allow us to identify these problems in the future. For this purpose, we need adequate surveillance systems with optimal implementation of interventions. So this requires monitoring any changes in exposure to vaccines, interventions, or pathogen agents. And this will allow us to assess any progress towards the program goals and ensure that we have the adequate coverage. And that will also allow us to assess the changes in determinants and inequalities. The third scenario relates to diseases that have already been eliminated. We will continue to apply the surveillance because in this regard, it is still critically important. We need to ensure that the disease that was eliminated does not come back and that we're dealing with the impact in an adequate way. And additionally, that any intervention that is undertaken in this regard is timely and effective. And so we see how surveillance from these different standpoints is absolutely key to be able to address our objectives in disease elimination. So the ethics that apply to surveillance and that Carla mentioned in her presentation include the identification of susceptible or disadvantaged groups and that are typically affected by diseases, especially by communicable diseases. We would need to, secondly, identify gaps in the access to services, not just health gaps, but access issues related to serious problems in populations. Many of these are driven by unequal access to uh, healthcare services, potable water, and other factors. Thirdly, we need to be able to use surveillance to identify those determinants that make it such that these diseases persist in certain communities. Fourth, we need to be able to communicate and intervene. This is a key part of surveillance. Fifth, we need to assess the impact of our interventions. And sixth, we need to involve the community in the complete surveillance process. So we need to include the population in a significant way in the entire surveillance process. Now, we share here the website that contains the more than 30 diseases that I alluded to earlier. And this is a page on the PAHO website that you can access information on. Now, there's a very fine line between research and surveillance when we talk about eliminating diseases. This line should not preclude us from undertaking surveillance. If anything, we should be able to clarify what differences exist because for surveillance, in the case of many diseases, requires populational assessments. And so in many cases involving diseases, we do need to use surveillance, but sometimes we run into that challenge whereby we understand the situation as research and we end up assessing the research components to be able to deal with the problem. Now, guidelines on the ethical framework of surveillance facilitate the efforts geared towards elimination of diseases. And it also saves us a great deal of time and it allows us to reduce the loss of life. Now, without robust, adequate, viable, and sustainable surveillance systems based on the principles presented by Carla, it'll be very, very difficult for us to move our disease elimination agenda. This is the current landscape for the region and this is recent information, we see many of the diseases that we believe we can eliminate in the region if we can accelerate the intervention and surveillance efforts that we have planned. So I leave you with that. Thank you, Carla, for the invitation to take part in this wonderful panel. Thank you very much, Marta. It's always a real treat to listen to your insights and the impact of the rigorously applied ethical surveillance system as part of the disease elimination initiative that PAHO is undertaking is absolutely essential. Now I'd like to present Dr. Roberta Caixeta, advisor for control of non-communicable diseases as part of the Department of Non-Communicable Diseases and Mental Health at PAHO. Go ahead, Roberta. Good afternoon. It's a real pleasure to be a part of this panel to discuss something that we believe to be an essential function of public health. First, I'd like to really celebrate the work of the Pan American Health Organization in its efforts directed towards non-communicable diseases. It's important for us to have ethical guidelines for surveillance directed at this particular subset of issues. And we have these guidelines available in 4 languages, and this will be very useful and helpful to people all over the Americas. So it's a real pleasure for me to be able to take part in this panel with other colleagues. What Marta was very important that we need to measure to understand when she mentions the importance of having indicators of measuring our progress and how we are performing. This is something that we need to take into account when we address issues of accountability. We need to ensure that this is a key component of our surveillance activities. Now, given the limited amount of time that I have, I'd like to reflect a little bit about the challenges involved in not having adequate public health surveillance that truly responds to the population's needs. I mention this because many public health surveillance systems at the national level, in many instances, are deficient and do not respond to issues related to communicable and non-communicable diseases. We still don't have a clear-cut understanding of the epidemiological landscape related to all of the population. We know that 80% of the deaths in the Americas are due to non-communicable diseases. And we have a very large share of the population, 24% in the Americas, that has at least one chronic disease that requires continuous care, that also requires an efficient, high quality response. From the service standpoint, we are facing some important challenges in this area. And if we don't change the framework related to non-communicable and communicable diseases, we will have an overburdened system in most countries where the quality of life for many populations will be extremely limited and will affect their autonomy. And this will only serve to worsen the inequality that we see. Surveillance needs to be able to respond to these different scenarios with great efficiency. We need to understand the relationship between communicable and non-communicable diseases. The populations that are at higher risk are typically people that live with chronic diseases, people that need to have their needs addressed over a certain timeline that is extremely challenging. And I'm not just talking about public health issues. We also see challenges in different populations that are subjected to humanitarian crises. And so we need to be aware and understand that any surveillance response that we undertake needs to be robust and needs to address the different decision-making procedures. We also think a little bit more about our definition of surveillance. It's the periodic standardized process that allows us to understand issues and policies, that the information needs to be available in a timely fashion for decision-making purposes. And at the end of the day, the information needs to be such that it can favor decision-making. We believe that in this regard, we are still underperforming. Oftentimes, the main element of surveillance, which involves the use of information for decision making, is not used in the way that it should be. I regularly say that if we conduct surveillance and we don't use the data that we collected, if we collect data and we don't use it for decision making, then we're not doing anything. It's certainly not surveillance. Surveillance is our way of establishing priorities. And I really like what's established in guideline number 1 regarding the importance for an obligation for each one of the countries to establish an effective, viable surveillance systems that will address the priorities. It needs to be sustainable, which is another challenge that we have. And this information needs to be able to direct our activities. And surveillance needs to be a priority based on the demands that are in place. And guidelines 1 and 5, I think, really address these issues. We need to be more aware and mindful of what's happening on the ground. I'd like to conclude by saying that surveillance allows us the tools to be able to navigate and to be able to navigate difficult situations. We need to have a robust surveillance system, one that is sustainable, to be able to move forward with our activities and make accurate decisions. And I think I'd like to conclude there, and I want to thank the organizers for the invitation to take part in this panel. Thank you. Thank you very much to Roberta. And now it's a real pleasure for me to introduce my colleague, Dr. Lionel Gresh, who's a lab specialist for the infectious threats department as part of the Division of Public Health at PAHO. And we've seen in the Q&A section that they've mentioned the COVID-19 pandemic. And I think in that regard, it's important for us to have the perspective from a colleague that has worked extensively in the emergency response arena. Go ahead, Leonid. Thank you, Carla. Good afternoon. Good morning to everyone. It's a real pleasure to join you here today. And once again, thank you to the organizers for providing me the opportunity to share some insights regarding the issue of surveillance and the ethical considerations that underpin public health surveillance. I'd like to focus on 2 key points. The first has to do with my personal experience related to research ethics, even prior to my work with PAHO. I worked as a researcher in the public health arena and infectious diseases, and we addressed bioethics related to our interactions with human beings. And the second point that I wanted to mention, and that has already been alluded to by Carla, I work for the Pan American Health Organization now, and so the public health surveillance ethical guidelines is something that I want to discuss. In both cases, if indeed the application of these fundamental principles related to public health ethics outlined by Carla and the need to customize them to the circumstances that we are dealing with, this is something that needs to be addressed. Much of this is held up by foundational principles that are applicable to all circumstances, but then we need to tailor our ethical solutions to the circumstances that we see. Now, when we talk about public health surveillance and more generally public health surveillance ethics, we see some important differences between research ethics and public health surveillance ethics. So research and surveillance do have some overlaying circumstances, but there are differences. Now, when we talk about surveillance, this is generally done by the health authority, and the differences in the objectives involved between the two sometimes presents challenges, and many of them related to the information and the approach to these differences need to be differentiated as well. Now, we also need to be mindful of the differences between collective and individual interests when we consider the ethical considerations related to surveillance. Now, some surveillance activities may have consequences for others, for the population, perhaps, that is not the same that we were considering in a research activity. Likewise, ethical considerations may be different between surveillance activities and what we would do in research. And so in some cases, we wouldn't be able to have the wherewithal to ascertain whether or not the surveillance that was carried out was effective or not. Now, when we talk about basic research, which proposes to, say, study the physiopathology aspects of a disease, and that maybe points to a short-term intervention, may bring about a larger impact to society at large. So the problem with not participating in research is less immediate than when we consider an activity related to a larger population. In research, we also usually consider that individual interests are protected through the process of informed consent, which we alluded to previously, as long as this process is carried out in the correct fashion. And it needs to be understood as a process and not simply a piece of paper or a form that needs to be read to a patient prior to conducting a study on that patient. And once they sign that document, we've actually overcome that particular objective. Now, in surveillance related to public health, as outlined by guideline number 12, the informed consent is not necessarily an ethical consideration or requirement. And this is something that Carla mentions frequently. The surveillance for a general impact such as Ebola. We understand that the local health authority may have the right and even the obligation to undertake certain diagnostic actions to be able to assess the existence of an Ebola pathogen. This may differ from what we do in other aspects. Now, this could be one extreme case, but we do see other situations in which it would not be necessary or even feasible to get informed consent. At the same time, this doesn't mean that any and every public health surveillance activity needs to be undertaken without informed consent. And this is an opportunity for us to highlight the aspects that need to be taken into account when we conduct the ethical execution of a surveillance activity. The first point that is mentioned in guidelines 1, 2, and 3, and that Carla also mentioned, relate to the purpose of the surveillance activity, the objective of the surveillance activity. And this is something that needs to be clear and legitimate. Additionally, the manner in which the activity is executed also needs to ensure that the data, that the information that we are collecting has the necessary quality that will allow us to meet the requirements and fulfill the objectives. I think this is absolutely essential, and it lines up very closely with what is required for research ethical considerations. When we review the ethics of a research project or activity, we can never justify exposing the individuals that are being studied to any unnecessary additional risk, regardless of whether or not we deem it to be minimal. Now, this cannot be done without the legitimate purpose that is considered in the planning activities leading up to the research.
The last point is who is in charge of doing that ethical review? And of course, and in every case, as we are, whether research or surveillance, those who are primarily responsible for activities to occur ethically are those who define, execute, and assess. In the case of research, we also have ethics committees who do work of analysis of the activities, uh, making sure that established ethical parameters are complied with. As you could see in these guidelines and also in Carla's presentation, the guidelines do not define a specific mechanism for oversight, but they uh, emphasize the need to have a practical, sustainable mechanism which ensures that the risks in surveillance activities can be systematically approached and transparently approached. And the second point I wanted to mention has to do with a public health surveillance in the context of an emergency. And it is related to guideline 15 of the WHO document. It's imperative that all parties involved share data timely. And of course, we're all clear that the need to share data in this case, public health surveillance data, is not limited to these contexts. However, when, for example, there is a situation with a disease such as COVID-19, which was new, or new clinical presentations are found in a known disease, as for example with Zika, and in other situations, the need to share data becomes even more important, and the timeliness of when we share the data, it becomes even more pressing still. And today we cannot understand how Oropuche spreads without having the surveillance data nationally and subnationally, and without knowing in what population groups uh, the problem is, and without having information about potential serious presentations. This also means that ethical analysis of surveillance activities that should be implemented in the context of an emergency, a health emergency, it needs to happen on a timely basis. And here we see a comparison again with the situation of research ethics for emergency situations. In research, we need to do ethical reviews, and the main adjustment here, even though it's not a simple thing, is to access the review with mechanisms that are straightforward and quick without affecting the quality. There's another point of uncertainty, especially when we are facing a new disease, as was the case with COVID-19, but also when we have a disease that is known to us, but is causing an emergency related perhaps to a new characteristic of the pathogen, or a characteristic that had not been previously recognized, maybe a new mode of transmission. Uncertainty, of course, needs to be taken into account when the commercial impact of the surveillance activity is analyzed, which means that we should also emphasize the continuing nature of ethical reviews. Uh, uh, and as Carla mentioned in her presentation, an example doesn't have, or so to give an example, it's not the same to uh, be doing surveillance on mpox when there is zoonotic transmission as opposed when it happens in men who have sex with men in those populations. So we need to be doing surveillance continuously and not before or at the end when we are doing a final assessment. And this is not specific of emergency situations. However, all those uncertainties that can occur in an emergency situation may lead to the fact that a continuous ethical review be even more pressing. And finally, I'd like to say that ethics in surveillance, ethics in public health in general, as well as in research, uh, it's not a matter for specialists alone. And I think we need to guarantee that an ethical analysis of a situation should always include interdisciplinary professionals and with engagement of the communities that are the object of the planning, etc. So I encourage you to review the guidelines that were presented here today and other guidelines that have been published before. And Carla, over to you. And thank you once again for inviting me to be here. Thank you very much, Lionel. Now it is a pleasure to introduce Dr. Oscar Mojica, Regional uh, advisor in social epidemiology from the Department of Evidence and Intelligence for Action in Action for Health. Over to you, Oscar. Thank you, Carla. Thank you for your invitation to participate in this very important webinar. I would say that this webinar is of great importance because of the topic that we're dealing with here, especially in this post-pandemic context. There are many lessons that we learned from the pandemic and still some more to learn. And one of them is the issue of ethics in surveillance and in public health surveillance. And I am being mindful of the time. So, but I would like to digress here. I remember a professor in med school who said, and this is over 30 years ago, we needed to establish expectatives. We need to establish expectations. When we talk about bioethics in general, it is in particular more important. There is always many more questions than answers. And yes, on the clinical side, on in the individual side, yes, there are many more questions than answers. But imagine this is multiplied even more so in public health because it is the collective, it's the summation of the whole individuals that are suffering clinical symptoms. It is difficult to have clear answers too on something that is so clear, is so clearly complex and subjective because there is subjectivity that is inherent in ethical matters, of course. Also, there's subjectivity when we are trying to define equity or inequity, what includes inequity or equity. And I'm not talking about equality here, but equity. Well, it is very hard to speak and follow other speakers, beginning with Carla and her great presentation, and then the panelists. But something that I wanted to underline, even though it has been said here before by other panelists, is this. It's surveillance per se. I think it's important for us to recognize, even though it is evident that surveillance in public health is an essential function of public health. Surveillance is an essential function of public health. And I would say that it feeds other essential functions, which is the situational analysis for health matters. And therefore, it is a priority for governance, for having a good governance to establish surveillance systems. We have many surveillance systems in our region, but but to the extent that our health care systems continue to be fragmented and segmented, to that same extent, surveillance systems might continue to be segmented and fragmented. This is not only the case for health systems alone, but it leads to inequalities. Fragmented and segmented systems perpetuate invisibilities and inequities. There are populations that feel they are going to be less surveyed and for whom controlling of surveillance may not happen. And so it's important to understand how surveillance in general is inextricably linked to the organization of healthcare systems to the extent that their fragmentation is perpetuated. To that same extent, inequities and inequalities in surveillance systems will be perpetuated. Another important aspect to emphasize when we say that it is an essential function in public health, in plain language, it's essentially a function that takes the pulse of the population health. Uh, and and there's another definition. It's an activity for advocacy. But I think it's a lot more than that. Surveillance is taking the pulse of the health of the population, and it is essentially collective in nature. And therefore, it is based on common good. And hence, as you will have seen and as described in the guidelines, something widely discussed because it doesn't have a response, is then that since it is based on common good, people can take certain liberties with it, as for example, restricting individual freedoms. And we saw that during the pandemic, and that's another complex situation. I think that we also ought to acknowledge that implicitly in any essential function of public health, in this case, surveillance, the state is considered to be the source of protection. The state, not the government. Surveillance is there to protect the population, especially emphasizing the way in which it anticipates. It's not only to do a count on the casualties, on the dead, on the sick, and not only for uh, communicable diseases. Surveillance, therefore, needs to be seen in that sense as a function of the state in its capacity as protector of the people. We know the state can also be a source of intrusion, and therefore it can impose additional burdens on the population, which entail discrimination. And as I said before, imposing restrictions to individual freedoms, as we have seen just now recently and with COVID-19 2021, 22. And this is something to take into account, especially regarding equity, surveillance of inequalities in health. And it is something that my team is dealing with for a while in PAHO. So, to that extent, I wanted to mention something that might be controversial because yes, we know the classical definition of surveillance, systematic and continuous observation of frequency distribution and determinants of health events and their trends in the time. So the three attributes that define epidemiology in general: frequency, distribution, and determinants. So basically, what we have developed in surveillance systems is the systematic and continuous observation of frequencies, but not of distribution, to the extent that we do not surveil distribution, we will continue to be blind to equity, as our director, our uh, 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 Dr. Etienne, um, because equity has to be with unfair distribution. It has to do with social justice. And let me make a small aside here to say that social justice is the basic principle for prosperous, peaceful coexistence of a group of people, and social justice is recognized to have four attributes, one of which is equity, the other is access, participation, and rights. Equity also is a social value. It is a virtuous aspirational quality that is paramount, uh, and has to do with social decision making, explicit or implicitly, but social decisions at the core have equity as the basis, which reestablishes impartiality. It's different from equality, which is a comparison of rights among all people. So equity is a social value, is a virtuous aspirational quality, which is paramount in social decision making, in the identity of peoples and their institutions, and in promoting the health of the population. In health, equity in health which should be understood as the state of total absence of unfair inequalities, not just any inequality in opportunities for healthcare to have a life that is decent, not only free of disease, but and this for collectives, for territories and that are determined socially and historically. So this is a definition of equity. And then we have a definition of surveillance, but there's another definition which perhaps will surprise us and therefore will lead us to take the topic of equity and moral conduct in matters of public health. When we hear this definition, surveillance is the close and continuous scrutiny on an individual or a set of individuals in order to detect any subversive trend. And this is a Napoleonic definition. This was said by Napoleon. So it's continuous surveillance on individuals to detect a a trend, a subversive trend. If we detect um, subversive trends, then we come to understand how essential surveillance is, but also ethics in the function of surveillance. In addition, together with this definition, we have the definition of control, which is the suppressing or repressing exercise of the subversive trend. The state knows this. All states know this, and they could be sources of protection, but the state can also be a source of intrusion. And this is what we need to surveil as well. And in that exercise of taking the pulse of the health of the population, all of this happens. Another thing I wanted to mention is that in the WHO guidelines, I don't see something. I'll finish in 30 seconds. But for me, ethical behavior or essential ethical principles are the gold standard or the golden rule of surveillance. I was an epidemiologist on the field, and I have worked in surveillance of disease in Peru, my country. So the golden rule of surveillance: make sure you do something on that which you are surveilling. It is not ethical to surveil, to measure, to count, to generate systematic information, or even uh, against some individual freedoms when we don't do anything to control what we surveil. And this should be a fundamental, essential guidelines. Finally, there are three guidelines among the 17 included in this important publication by the WHO and PAHO. Uh, and this is a publication we've had with us for a while related to equity and social justice. It's 4, 5, and 9. Number 4, it says that that the states have to have clear public health objectives, because those objectives are going to dictate the objectives of surveillance. If we do not include equity specifically, then surveillance won't have as one of its objectives equity, and we continue to count only average frequencies. Guideline 5 also states that we need to have health priorities, because it is health priorities, those that dictate priorities for surveillance. Once again, if equity or distributive justice is not a priority in health, then we cannot request our surveillance to be surveilling equity. We couldn't be, or we shouldn't be surveilling that in any case. And finally, number 9 talks about the need to surveil vulnerable populations without violating their rights even more. For example, for example, tuberculosis in migrant populations. And this is a hot topic, both tuberculosis and migration. These are hot topics, but they are complex and they require a lot of debate and consensus. Yes, and I'll stop here. I don't want to take more of the time allotted to me. Thank you. Thank you, Oscar. The point you were said that was not covered, it is covered. The importance of using surveillance information. That's what Roberta mentioned. Yes, you collect data that eventually you don't use, and that's not ethical. Now I invite all the panelists to be here, and I will like to invite Maria Roderick Molins to facilitate this conversation. We have had a great deal of questions. So, Roderick, over to you. Thank you, Carla. Yes, yes, we have a whole bunch of questions. Let's hope we have time to answer them all. And to begin, I would like to ask the question to all of the panelists. What is the ethical relevance in disaggregating data? For example, collecting data related to sexual orientation and gender identity. So whoever wants to answer or tackle this question, please, over to you. Oh, well, no one is volunteering here. Well, if I want to tackle the topic from the lessons learned from research ethics. Erroneously, in research uh, ethics, we have believed that protecting means not to do anything, to move away, not to collect information, etc. What we know today is that if we don't look, we are making inequalities and inequities greater. If we don't know how a disease is distributed or risk is distributed in a population, we won't be able to develop specific measures for the populations who need it. And it is in this sense that data disaggregation is important. And there could be a very powerful justification to have disaggregated data by sexual orientation if this is what will allow these populations to get what they need and look for those mechanisms for these populations to have appropriate access. Martha, over to you. Thank you, Carla. I think that we go back to the beginning of for what? For what? Unfortunately, when we do surveillance, but also research, we simply want to ask everything. And we go back to what Oscar said, we will collect a whole bunch of information that ends up not being used just because we say, oh, since we're going to ask, let us ask 120 questions and let's include gender, sex, pregnant, teenagers. What is the objective? Public health surveillance necessarily must have objectives. What for? In what populations do I need to understand the phenomenon I'm trying to surveil? And this will lead me to know the variables I need to collect and what are the data that we need to have. So the question beyond whether collecting information about a person's sexual orientation is ethical or not, I think the ethical question is the information I'm collecting will allow me to do interventions, yes or no? Thanks. Lionel? Yes. Yes, quickly and uh, dovetailing on what Martha said, first we need to define the objective and then, of course, see how we collect the information, how we explain to the population why the information is being collected. And of course, bearing in mind that the fact that we're collecting it, it doesn't mean that it will be information as any other. Of course, gender, sexual orientation may be information that is collected and will be kept in a databases, and if it is collected and kept, then it can have certain risks. So we need to guarantee confidentiality of that information. And as Oscar said, again, why do we collect the information? What are we going to do with it at the end? And how are we going to guarantee that the risk in the end, the risk for the people in that population is, and there's always a risk that confidentiality cannot be maintained, etc. So how do we balance the risk with against the benefit of the action that we're going to take uh, based on the results of that surveillance?
Yes, I'd like to follow along the lines of the why of it all. I think those of us that work in surveillance and produce data, we want to produce data that address all of the social determinants and identifiers, and we want to be as comprehensive as possible. The challenge I see very frequently, and I live day to day with the since I'm doing this kind of thing, since I'm doing this survey, we invariably fall into that trap. So without being aware to aware of what we're doing when using this approach, then we lose sight of the purpose. That very frequently I invite colleagues and I try to instill in them that when they do advocacy, when they're working on something that's important, I think we talk in very highfalutin terms. We like to really try to address the general bigger issues related to public health. But many times we fall into the trap whereby in order to not leave any stone unturned, we end up getting uh, bogged down in the collection of data or information that will not give us what we need regarding a specific condition or disease. And this is not very helpful. Many times the reliability or confidence interval isn't very broad. And I end up collecting information that doesn't really serve as the proper orientation for what we want to do. I'm a big proponent of disaggregating data. We need to use resources that will allow us to use data that really corresponds to the needs that we have in the surveillance arena. Thank you. Oscar. Thank you, Rodri. I'm going to lower my digital hand here. I agree with everything that's been said. In fact, I think that in principle, when we get back to the question, we are looking at a couple of different things. On the one hand, the response is closely aligned with the purpose of the surveillance. If we have a properly defined priority to surveil, for example, any aspect related to a disease and anything that may require the disaggregation of the information, that we would have to do that. But this is something that is included implicitly in the purpose of the overall surveillance. But the other thing that I think that is important that we see very frequently is that we're talking about the difference between surveillance and research. And this syndrome of, since we're doing this, we end up doing more than what we have to meet the requirements of our purpose. So when we talk about all of the indicators, inequality, social factors, etc., this happens when there's a confusion between the objective for research versus the objectives for surveillance. That's why sometimes the things get blurred. We don't necessarily pinpoint what we need to do. And this happens to us in life because we want to apply the principle of efficiency to surveillance. And many times we end up working against ourselves. We can't have interventions with known efficacy to resolve a problem. And many times we don't have sufficient power or strength of proof because we're talking about confidence intervals and ethical considerations, and yet we are losing sight of very foundational elements. So when we talk about surveillance, we need to be more specific to be able to inform decisions, to be able to change the policy incidents. So we have to act on social determinants. And therefore, I think it's important for us to make the clear distinction between research and surveillance, and even the distinction between epidemiological research. And we need to get away from discussing merely clinical trials and individual cases. I think there was a question, it was one of the first questions that asked if it would be unethical to reduce the number of variables. That is, to have information on the sexual orientation of a subject as part of the surveillance and collapse it down into a simple male-female dichotomy. That to me would be an ethical consideration, but the specific surveillance objective should be the one that carries the day when it comes to the decisions of that nature. Thank you. I think this is a question that is better geared for Lionel. Lionel, what is the role or the impact of surveillance when we talk about emergency response issues, and anything you want to share in that regard? I think that first and foremost, when we talk about preparedness and emergency response, this is a key component of public health, and the answer would contain the surveillance elements that relate to the emergency. This is uh, an obligation, but moreover, it's a legal obligation for the various healthcare systems, the detection and the capacity to respond with efficacy to any incidents of this type is a national obligation. And as we as PAHO or WHO also have this obligation. And when we get back to the guidelines, we have an obligation as international healthcare organizations to support the countries to strengthen their emergency response and intervention capability. As I was stating in my comments previously, I think there is a critical aspect related to surveillance as it pertains to emergency response. A lot of it has to do with timeliness, opportunity. We need to be able to share the data in a much more expedited way. We also need to have expedited data analysis capability, and that extends to sharing the data. And this is primarily geared towards dealing with the uncertainty having to do with an emergency that we're not familiar with. More than pointing out the specificity of surveillance within the context of a healthcare emergency, I think it's more important for us to highlight the similarities between the ethical analysis in any different activities. Sometimes in an emergency, we don't have all the information we need. We don't know what could lead to an even greater, more exacerbated risk or harm to the general population based on the decision process to determine what activities we're going to be executing. But I think that the general principles that we've been discussing throughout the course of today's session are continuous and constant. They don't change. I'm sorry, Oscar. For some reason, I don't have access to my digital hand, so I'm going to have to chime in here. I had raised a hand privately for Rodri, but getting to what I think you wanted to talk about, and I was thinking that perhaps the question is broader, more complex than what you responded to. There's one thing related to surveillance, related to the cause of an emergency, and there's a difference between that and surveillance that once we are aware of an emergency, we need to understand what the elements are for the emergency. We need to be independent of the other. So why do I talk about this? When we look at challenges to responding to COVID-19, for example, we realized that there were other issues about which we didn't have sufficient, clear surveillance data. And we didn't understand how many people we had under specific risk due to COVID. And this included people who had diabetes or were people that had chronic diseases. Although these were not COVID specific, they were a key element in being able to respond adequately to the emergency. Thank you, Carla. I also wanted to mention briefly, and I agree that in essence, the ethical principles and guidelines that are contained in the guide are pretty constant, regardless of emergency or non-emergency situations. But I do think that there are circumstances that are fundamentally different. For example, sustaining surveillance in conditions that are not eh, defined as emergencies. And we need to have something that's in everybody's thoughts these days, resilience. So, for example, during an epidemic or a pandemic, being able to sustain routine surveillance system to ensure that they don't collapse, because in principle or at the beginning, we can't know that the current problem, the pandemic, COVID, for example, may have repercussions either directly or indirectly on other pathologies, as it turned out to be. But something that's fundamental for me, because this has serious implications for all of us, we've all experienced it, and especially those who experienced this in jobs at a very high level, because there were many policy issues related. And this relates to accountability, our ability to be accountable. So in an emergency, a surveillance system needs to ensure that it's transparent and that it does prove to be accountable, that it is accountable. And one of the lessons we learned from COVID was that we realized that the pandemic very quickly helped us understand that we were blind to the issue of equity. And this really opened a Pandora's box, because then all of a sudden it wasn't just necessarily to surveil those vulnerable populations, but we needed to add other populations to the system. Or maybe it was a transactional trade-off. We would have to trade one thing for another because we had to ascertain the agility that the surveillance system could have to respond to the pandemic. But we invariably started adding important elements, additional elements, or we can believe that digital surveillance with machine learning or AI through mobile phones may be able to bring about more rapid responses. And that may be the case, but that could open another Pandora's box, of course, because it makes us susceptible to the violation of individual rights. And given now that in social media, it's very easy for us to disseminate personal confidential information that can be used to stigmatize certain groups of people, this becomes then a very complicated matter. So I think that the guidelines will have to be broadened to address this very rapid transition that we're experiencing with the digitalization of everything, the AI things. And I think in general, public health systems and in specifically surveillance systems need to address these things, and not just from the standpoint of the state, but rather from the standpoint of providing a special emphasis to instruction and not so much dissemination. Well, we are running out of time, and there's a question directed to Marta and then another one directed at Carla. So let's start with Marta. Marta, how do you relate the surveillance with access to remote areas or rural areas that are hard to access geographically speaking? Well, thank you to the participant that posed the question. When we talk about geographical access for populations that live in remote or rural areas, this is a very difficult situation. We're talking about populations that perhaps for decades have had difficulties in access to services, and the needs related to healthcare are either not understood or other populations are prioritized over some of these remote populations because it's easier to address their needs as opposed to the needs of the folks who have geographical access issues. Now, when we have dispersed populations living in remote areas, we need to collect data, identify the problems. And when we do that, we still don't do anything for those populations. They continue to live under very neglected conditions, and we need to come up with specific plans for these populations. It's clear that these types of populations require surveillance systems. There are none for them. There's no baseline. Wherever there's a baseline, there's no follow-up information or surveillance activities. We don't understand the factors or barriers that restrict the access for those populations. Additionally, there's very weak local capacity in terms of responding to the needs of those communities. And we're not talking about the building or establishment of healthcare centers. We're talking about Chaco and the Amazon region, different areas where dispersed populations live under very remote, isolated conditions. And the idea would have to be how we could come up with the proper responses using a multimodal approach. And so surveillance would allow us to adapt the national and sub-national response capability to be able to deal with the issues faced by those local populations. So it's a huge problem because we could still fall into the trap of just collecting data about those people, but not doing anything for them. Thank you, Marta and Carla. The question to you is, how can we relate these ethical surveillance guidelines with the uh, fundamental circumstances of these indigenous policies and that have been identified by the UN? Well, I think this is something that's clearly related to what Marta was talking about just moments ago. I would like to clarify the difference between ethics and the legal instruments and frameworks that provide oversight for human rights. It's not true that our ethical vocabulary should or can or will be reduced to that which can be captured in a legal instrument. In a legal instrument, you capture only the most basic considerations, the most foundational considerations. And I think COVID-19 really made this very obvious, and it highlighted the problems that we have in the system. And we saw the entire spectrum of what we could do, we had the capability to do, and it reduced it to the legal uh, foundational elements. And so this is neat. It's very hard for us to capture everything out there in a single legal instrument, be it the rights of indigenous communities or any other UN legal instrument that has any relationship with the issue of health. Most of what we do is focused on the challenges related to surveillance, but the type of use is also different between frameworks because it calls for the ethical analysis of concrete cases. If you think about what we've been talking about with regard to the first question about data disaggregation, then the answer could be, well, it all depends. And it's not that we have an algorithmic answer. It's not a code that is used in all cases. The ethical guidelines for surveillance, just like other ethical guidelines for other areas, is to drive an ethical analysis and review about specific cases. And this is something that I really wanted to point out because the idea is that we need to provide substantive guidance, but it cannot become just a mechanical situation. It's not like getting into your car and putting on your seatbelt. We need to undertake the ethical analysis, and that's why this is key. And I see that Roberta raised her hand. Just to go back to something mentioned by Oscar, and that's also considered in the guidelines, and it relates to invisibility. Sometimes population, and this links us to the question about indigenous populations and other populations. Many times when we don't have a way to illustrate the issue of non-communicable diseases. There's a great deal of need for understanding and information about true needs. So getting, accessing, and reaching out to these populations, getting the information that pertains to them, and understanding in a much better way the barriers to service access, many times involving a number of barriers, not a single one. So we need to ascertain what those barriers are to collect healthcare or health information that will allow us to direct certain interventions that can help us start closing some of these inequity gaps that we have. Oscar, were you going to chime in here? I think that we've already heard it. I mean, when we talk about rural populations, this is really key, especially when we're talking about a context of disease elimination. As we all know, those that are closer to the elimination effort are typically populations that are territorially very concentrated. And the real problems involve the dispersed populations in very remote areas. So that's where we would need effective, cost-effective interventions to be able to address the needs of those populations. This is going to require an effort of great magnitude, and that's being promoted by the organization to be able to carry it out. The other thing that I wanted to mention that I believe has a direct relationship with ethics, and there was a question in there somewhere, and I agree completely. Equity, social justice, human rights, and ethics are completely related to each other. You can't have one thing such as social justice and not protect human rights, or not address the principle of equity. These are key elements in the discussion that has brought us together to discuss these ethical considerations. But because of the political connotations that these things have in general, we sometimes neglect the issue of social capital. So an ethical surveillance system in public health care with ethical features, such as the ones that we are discussing, such as the ones defined by PAHO and WHO, give us a system that strengthens our social capital. And social capital is a measure of good governance. And to explain this, let me just say that social capital is a very rich, very important reserve, the reserve of social assets that are shared based on the principle of reciprocity that leads to social cohesion, credibility, and trust in institutions that we saw came back after COVID, and a general concern for the well-being of others are all features, aspects of good governance and a healthy social sector. Any surveillance system that fails with regard to any of these principles will be putting at risk the trust and the credibility of institutions. And we saw this during COVID. The mere fact that some people did not want to get vaccinated was a sign, it was a symptom of the lack of credibility in the system. And this could easily be considered, among other things, as one of the failures of the system. So for me, the surveillance system needs to be explicitly understood to control and inform in the good sense of the word, not in the sense of the Napoleonic example that I gave previously. But so just to conclude, we just have a couple of minutes left, if we could ask all the panelists to give us some suggestions about a question related to how countries in the Americas could continue to strengthen their ethical framework as it pertains to public health surveillance. 1 minute for each, please. Thank you. I have a quick response, which is not politically correct. But for me, trying to put in practice each of the guidelines that we've discussed today, each of the ethical guidelines. That's the road for me. And of course, as part of this ethical framework, we need to prioritize health considerations as well as surveillance considerations. Roberto, since you opened your mic, just joining Oscar in what he said, I would highlight sustainability is key in all of this. Lionel or Marta? Well, from my standpoint, I think that we need to focus on needs and the response for these needs. I think this would be a proper application of the surveillance ethical guidelines. And I would mention that though I agree with what everybody said, we should learn from the progress that we've made at a regional level in the research arena, especially in terms of the identification of the needs that we have in public health and the surveillance that's required. We need to also understand that surveillance is not just the purview of specialists. This is something that we need to instill in everybody, healthcare workers, and even the communities that we serve. I'd like to take advantage of the opportunity to just delve a little bit more deeply into what Lionel just said. And something that I received from my work experience through all of the colleagues that engage in surveillance for PAHO. Without that close network where we collaborate and that we think in a collective way about the technical challenges and how we respond to them, we're not going to move forward very quickly. Surveillance is not separate from the work that healthcare professionals do on the ground. And the vision for the surveillance program at PAHO is to establish this link between the healthcare work that we do on the ground and the ethical considerations. Without this work, this joint effort, and of course, we need to put the guidelines into practice. We need to ensure that healthcare professionals think about these ethical considerations in all cases. Without this, we're not going to be able to move the needle forward. But when we talk about difficult cases, those cases in which we run into something that as a healthcare professional, we could say, I understand what the guidelines say, but I'm not that persuaded as to what the best argument would be from an ethical standpoint. So we would need to then know who we could call upon for support. Clearly, we always have our doors open and are always available to help anybody in the region. But when we get back to issues of sustainability, then we need to ensure that all healthcare authorities in our region have somebody that can address public health ethical issues. And it could be a person that when the implementation of the guidelines becomes challenging, that could be the go-to person that for issues related to surveillance or any other matter could serve as a resource for us to better understand how to proceed from an ethical standpoint. So we're 2 minutes away from closing down the session. I would like to thank our distinguished panel. I think that this webinar didn't just capture this moment during these 2 hours of thought, but it also captured a long time of work related to the definition and development of these ethical guidelines that we very happily shared with all of you. I did want to highlight that the recording of this session will be sent through the public health ethics list, and it will be available both in English and in Spanish. And we will be sharing with all of you a way to access the links to the materials that we discussed today. Thank you very much. Have a wonderful day.